So here we are going to discuss to learn some information what we need for NCLEX board exam. The first information about the sickle cell anemia. So a patient with normocytic hemolytic anemia means the red blood cell size is normal. Also, patient has a anemia because of hemolysis, who has electrophoresis result of hemoglobin A with a 20% concentration of hemoglobin F as sickle cell anemia. So when a patient is diagnosed anemia, to evaluate the underlying cause of anemia, we need electrophoresis. And after the electrophoresis, we see the patient has a sickle cell disease. Electrophoresis is not used to diagnose hemolytic or aplastic anemia, but electrophoresis help to diagnose any kind of genetic defect like sickle cell anemia. Thalassemia, major appearance within the first 2 years of life, associated with life-threatening anemia. Thalassemia major associated with non-hemolytic and normochromic anemia, right? Normochromic, they said. So from this note, what we learn? We learn electrophoresis basically need to evaluate anemia if it is genetic disease like sickle cell disease or thalassemia. But if patient have a anemia because of hemolytic or aplastic, we do not need electrophoresis. Thalassemia major usually appear within the first 2 years of life and associated with life-threatening anemia. Thalassemia major is associated with non-hemolytic and normocytic anemia, right? So next question here. Type 2 diabetes mellitus. When go for laboratory test, include the fasting plasma glucose level must be more than 126 milligram per DL. It is fasting. Random blood glucose level supposed to more than 200 milligram per DL. Oral glucose tolerant test for 2-hour blood glucose level more than 200 milligram. And with a 75 glucose load. And normal hemoglobin A1C, it is called glycosylated hemoglobin, level are less than 6. So my friend, it is important to share with you. If a patient has a diabetic, and we need to evaluate, and also after the evaluation, we are get confused. We need a confirmation. Confirmation we can get by hemoglobin A1C. Hemoglobin A1C basically called glycosylated hemoglobin. So what your blood sugar level last 3 months, you will get a confirmation by this. So if any patient glycosylated hemoglobin or hemoglobin A1C less than 6% means he or she does not have any diabetic, or if anybody have a diabetic but hemoglobin A1C less than 6% means he is well controlled. So what are the other basic tests we do or we get for diagnosis or evaluate the type 2 diabetes? Include fasting blood glucose, random plasma glucose, and oral glucose tolerant test with a 75 gram glucose load. What does it mean? It means You take 75-gram glucose intake and then you do the test. Oral glucose tolerant test, 2-hour blood glucose level, right? It more than 200 milligram per DL means patient maybe have diabetes. Random glucose level, if it is more than 200, random means you took the breakfast or lunch or dinner, or you ate something in the day and then go for the blood glucose level. It is more than 200. Then it indicates diabetes. What about the fasting? You do not take any food, any breakfast, anything. So it's supposed to more than 120 milligram per DL. Then we can say this patient has a diabetes. Wonderful. What next? Next here is something called Sonogai phenomenon or Somogai phenomenon. What is that? Somogai phenomenon is caused by the too much insulin in the evening, which result in hypoglycemia in early morning. Usually 2 a.m. to 3 p.m. we call it midnight, but it is early morning, right, my friend? So if a patient have this problem, what we could do, it is good to test the blood sugar in early morning, like 3 a.m. or 2 a.m. The body compensates by secreting glucagon from the liver and epinephrine. So our liver can secrete glucagon, and glucagon metabolize the blood sugar, and blood sugar go down, and patient present with hypoglycemia, which result is the high blood glucose level in the morning. The Somogai phenomenon is also known as rebound effect. Let me read it one more time for you. Somogai phenomenon is caused by the too much insulin or missing a meal in the evening, which result hypoglycemia in early morning, like 2 a.m. or 3 a.m. The body compensates by secreting glucagon and epinephrine, which result in high blood glucose level in the morning. The Somogai phenomenon is also known as rebound effect, right? So if NCLEX board asks, what is Somogai phenomenon? It is hypoglycemia because too much insulin or missing meal or snack. What next? Next, a condition for endocrine disorder is called myxedema. So myxedema or myxedema coma is seen in the patient with a severe hypothyroidism. So if any patient has a severe hypothyroidism, means thyroid stimulating hormone is too high, but T4 and T3 is very low. With sign of symptom, patient present with hypothyroidism. So it is the complication of hypothyroidism, myxedema. It referred to the skin change, like thickening the skin. Also, skin change seen in chronic severe hypothyroidism. It is a medical emergency with mortality rate exceed 20%. It is treated with high dose of thyroid hormone. So patient is hypothyroidism. They need T3 and T4 to correct the hypothyroidism condition. If patient is maltreated, no treatment, and complication arise, myxedema, coma, right? So how we treat it or how can prevent it? By treatment of high dose of thyroid hormone, T3, T4. A thyroid storm occurs when there is an extreme elevated of thyroid hormone. So myxedema, coma, and thyroid storm, it is just opposite, right? I said myxedema, coma because of severe hypothyroidism, and patient need thyroid hormone replacement. But thyroid storm occur when extreme elevated of thyroid hormone, hypothyroidism. Thyroid storm is life-threatening and life if it is untreated. Majority mortality rate about 90%. It is emergency, so call 911 if suspected. What is Graves' disease? Graves' disease associated with thyroid hyperfunction or hyperthyroidism, right? So what we learn from here? We learn if patient has a hypothyroidism, complication lead to myxedema, coma, and treated with high dose thyroid hormone, T3, T4. If patient has hypothyroidism or elevated thyroid hormone, they have a complication called thyroid storm. And we need to call 911. And Graves' disease is associated with thyroid hyperfunction or hypothyroidism. Make it easy again. Hypothyroidism complication, myxedema or myxedema, coma. Hypothyroidism complication is thyroid storm. Both are medical emergencies. What next? Next here, the Cushing syndrome. So Cushing syndrome associated with delayed puberty and growth failure in the children and adolescents. Patients with Cushing syndrome have a excess androgen, not estrogen, androgen. So if you read this name, it is called CUS, right? And HING, whatever it is. But I want to tell you, my friend, U for up. So too much steroid hormone, too much androgen hormone. When our body tissue exposed continuously too much steroid or too much endogenous hormone, patient develops sign symptom we call Cushing syndrome. So what are the presentation? Patient present with gynecomastia and not pseudogynecomastia occur with the Cushing syndrome. And pseudogynecomastia is also caused by deposit of fat, whereas gynecomastia is caused by excess cortisol. So Cushing syndrome, there are few cause patient present with the Cushing syndrome, right? So maybe endocrine defect or too much steroid hormone for a long time. What next? Next here about one of the insulin called insulin LISPO. LISPO is a rapid acting insulin that is used on a sliding scale to work from meal to meal. Insulin isofen or insulin regular is a mixed, intermittent, and short-acting insulin and would not be appropriate for sliding scale. Insulin glargine is given once a day. So what we learn? Insulin glargine we can give once a day. It is good, right? Patients do not need insulin peak again and again. If they took insulin glargine once for all day long, 2 to 4 hours, patient will be happy. And NPH is an intermediate acting insulin that is not appropriate for sliding scale. So what are the information we learn from here? One is insulin glargine is good because it is given once a day. And also we learn NPH is an intermediate acting insulin and it is not appropriate for sliding scale. So what is appropriate for sliding scale? This is LISPO. And LISPO is rapid acting insulin that is used to sliding scale to work from meal to meal. Right? And also insulin, another insulin called isofren and insulin regular is a mixture of intermediate and short-acting insulin and would not appropriate for sliding scale. If we make a summary, make a short note, we learn 3 points. One is for sliding scale, LISPO is the best. And LISPO is a rapid acting insulin. Or for sliding scale, rapid acting insulin is best. Insulin glargine only gives once a day. And NPH as intermediate acting insulin not appropriate for sliding scale. What next? Next here, a medical condition, it is called Hashimoto disease, right? Hashimoto thyroiditis is an autoimmune disorder of the thyroid gland that is the more common in women than men. Thyroid peroxidase level are the gold standard for diagnosis. Elevated level of confirmed diagnosis as well. Patient present with a weight gain, cold intolerance, goiter, and also elevated the cholesterol level. Thyroid cancer present as a hoarseness and problem with the swelling or swallowing, like dysphagia, dyspnea, and cough. There is a higher prevalence in women and in women aged 20 to 55 years with a family history. Another condition called pherecytoma. Pherecytoma causes the episode of headache, diaphoresis, tachycardia, hypertension. So after an attack, the vital return to the normal and hyperprolactemia can be sign of pituitary adenoma. It is benign condition, has a low onset. Serum prolactin is elevated and women can present with amenorrhea. As a tumor growth, it will be affect the vision and causes the headache. So from this note, we'll learn few medical keyword like Hashimoto thyroiditis, Then we learn what is the pherecytoma. We learn hyperprolactemia, right? So let me talk one by one. Hashimoto thyroiditis, it is the autoimmune disorder, right? And it is more common in the female than men. And you see the ratio 8:1. So thyroid peroxidase, it is called TPO. It is the gold standard for diagnosis. Elevated level confirm diagnosis. So normal TPO supposed to less than 35 international unit, but if it is more than that, elevated for a long time, we said Hashimoto thyroiditis, because TPO, thyroid peroxidase, is a gold standard. Patient present with a, what are the presentation? Weight gain, cold intolerance, and goiter, also elevated cholesterol level. You see, weight gain, cold intolerance, and goiter, enlargement of the thyroid gland, elevated cholesterol level, very important. Another word is called, another disease condition called thyroid cancer. How you differentiate thyroid cancer with Hashimoto thyroiditis? Thyroid cancer patient present with a hoarseness of voice. So if a patient has a thyroid problem, also hoarseness of the voice, it highly indicated of cancer. Also problem with swallowing, like dysphagia, dyspnea, and or cough, shortness of breath, and difficulty of deglutition. And this is highly prevalent in women, 3:1, as like as Hashimoto thyroiditis, also more common in the female. And also PKs 30, 22, 35 years with a positive family history. So it is another factor. What about another medical condition? We talk about the pherecytoma. Pherecytoma is the tumor of suprarenal gland, particularly inside the medulla. So example, if the suprarenal gland look like this, the outer layer we called, this is the outer layer cortex, and inside is called medulla. So tumor formation in here, pherecytoma, and this tumor, excess growth, excess secretion, this secret too much endogenous hormone. Pherecytoma causes episode of patient present with huge increase the blood pressure and headache. Headache, diaphoresis, tachycardia, and hypertension. Blood pressure go up. Tachycardia, heart rate go up. Sweating, diaphoresis, and headache. So it is the typical presentation of pherecytoma. Every student must to know. Another condition here, it is called hyperprolactemia. What is that? Hyperprolactemia can be sign of pituitary adenoma, and it is benign condition. But pituitary adenoma, it is hyperprolactemia, right? Has a slow onset, and serum prolactin is elevated. So how we know my patient have this problem? Serum prolactin level is elevated. So it is called hyperprolactemia. And women can present with amenorrhea. Okay. As the tumor growth, it will affect the vision and cause the headache. Now this problem, a note is here, iodine is a central component of thyroid hormone. So iodine, right? So which is regulate the growth, development, and metabolic rate. So every day we took some salt, and salt contains the iodine. And what are the role of iodine in the body? Iodine is an important component of thyroid hormone, which is regulate our growth, our development, and metabolic rate. Low iodine level result in hypothyroidism. A patient deficient in iodine will present with weight gain, lethargy, and goiter because of hypothyroidism. If deficient in calcium, a patient present with impaired growth and osteoporosis, bones erosion. When deficient in fluoride, the patient present with dental decay and subject of osteoporosis. A sodium deficit present with restlessness, irritability, muscle weakness, cramping, and possible nausea and vomiting. So from this note, there are few information, right? So one is sodium deficiency, one is calcium deficiency, and iodine deficiency. So if NCLEX board asks if a patient present with sodium deficiency, what should be presentation? Patient complain of restlessness and irritabilities, muscle weakness, muscle pain or cramping, and possible nausea and vomiting. So if your patient present with this sign symptom, I easily can say this is the sodium deficiency. What else? Calcium. So deficient in calcium, a patient with present with impaired growth and bone erosion. What about the fluorine? Fluorine present with patient with present with dental decay and also osteoporosis. But fluorine is important component our dental. And the major things from this note we learn is iodine, right? So we already know that. I want to recap it. Iodine is important for our growth, our development, and metabolic rate. When low iodine, result of hypothyroidism. So hypothyroidism reduce the iodine, or reduce the iodine lead to hypothyroidism, and patient present with weight gain, lethargy, and goiter. Let me tell something more from here. A patient is moderately obese with BMI 32.5. So my patient is obese and BMI is more than normal and is 32.5. Blood urea nitrogen and creatinine are within normal limit but should be monitored. Metformin. It is the medication for diabetic. Metformin, other name is, trade name is biguanide. Metformin is preferred for obese patient because it helps with weight loss. So if a patient has diabetic because of obesity, we give them metformin. There's so many female weight gain and they have a PCOS, polycystic ovarian disease, and they need to reduce their weight. We give them metformin, but patients do not have diabetic, but metformin is a drug of choice. So sulfonylurea stimulate the beta cell, but have a long half-life, and there's a high risk for severe hypoglycemia event. So metformin is better than sulfonylurea. Because sulfonylurea, patient have chance to hypoglycemic condition. Another medication for diabetic is called thiazolidine or thiazolidinedionates. Should not be used with patients who have a history of bladder cancer or heart failure. Another drug is called meglitinide, stimulate the pancreatic release of insulin, are indicated for patients with a postprandial hyperglycemia. Means when you eat, after eating, your blood sugar go up, and that times meglitinide is good. But the best medication for obesity, for diabetic, it is metformin. Few things more about myxedema coma. Myxedema coma, severe hypothyroidism. Myxedema coma is a life-threatening condition that may develop with abrupt suggestions of thyroid replacement therapy. Now, a patient with a hyperthyroidism and patient develop Graves' disease. So Graves' disease, because of hyperthyroidism, are the risks for osteoporosis and arterial fibrillations. Important. A patient has a hyperthyroidism, he or she has a risk to develop osteoporosis and atrial fibrillation. The most appropriate medication to add the treatment regime with the warfarin, because patient chance to develop atrial fibrillation. So we need blood thinner, which treat the atrial fibrillation. Other medication, it is called diuretics or Lasix furosemide, is prescribed for heart failure patient, which is not the risk factor for the patient with hyperthyroidism. So a patient has a hyperthyroidism and heart failure, we can give Lasix. A patient has a hyperthyroidism with a atrial fibrillation, we give them warfarin. So another medication called cholestyramine, it is the medication to reduce the cholesterol, is used for hyperlipidemia. A beta blocker such as atenolol is normally prescribed when a patient is first diagnosed with a Graves' disease, right? So what we learn from here? We learn a patient has a hyperthyroidism with atrial fibrillation, we give them warfarin. A patient has a hyperthyroidism with heart failure, we give them furosemide. A patient has a hyperthyroidism with hyperlipidemia, we give them cholestyramine. If a patient has a Graves' disease, we also can treat by atenolol. So beta blocker, when a patient, the first diagnosis with the Graves' disease, because patient has a tachycardia as well. Also, it is less than the hyperstimulation. What next? Next here, the symptom of hypothyroidism. What are the symptoms of hypothyroidism? It is include fatigue, cold intolerance, weight gain, and constipation. How I remember? I remember hypothyroidism, H-Y-P-O, hypo, this is a O, right? Hypo. Patient has a cold, C-O-L-D-O, another O, cold. And patient has a constipation, another O, right? So, hypothyroidism, cold intolerance, and constipation. O. But now question, my friend. Weight gain, you say, this is the opposite. Most of the patients who have hypothyroidism, most of the signs symptom is go down, except weight gain. Patient eat, appetite is increase, right? But metabolism rate go down and weight gain. And patient, when metabolism go down, not enough ATP and fatigue. A patient with hypothyroidism, they said, would present with weight loss. It is opposite to weight gain, anxiety, palpitation, feeling hot or warm, and insomnia. So hyper, everything is go up. Appetite is good, but patient metabolism rate is go up. So weight loss. Anxiety increase, heartbeat increase, palpitation increase, tachycardia, hot skin, and insomnia. Every exam gives some question from hyperthyroidism or hypothyroidism. You have to know. Diabetic mellitus symptom include polyphagia, polydipsia, and polyuria. You see, easy to remember, 3 P's. 1 P for polyphagia, means too much eat. Polydipsia, feeling thirsty always. And polyuria, too much pee out. A patient with heart failure would present with, if patient have heart failure, present with respiratory symptom, weight gain because fluid retention, tachycardia as like as hyperthyroidism, fatigue like as hypothyroidism, and edema, fluid retention. You must know for your board exam. What are the signs, symptoms of the heart failure? Respiratory symptom, shortness of breath, weight gain, trachypnea, fatigue, and edema. Next here, if a patient have a sign symptom of diabetics, we go for the test for confirmation. It is called hemoglobin A1C. So the treatment goal for the patient who has a present with high blood sugar or diabetics, the treatment goal for hemoglobin A1C must be less than 7%. It means if you have diabetic and after medication or lifestyle modification, if you see your hemoglobin A1C less than 7%, means it under control. If you do not have any diabetic before, and if hemoglobin A1C less than 7%, it means you do not have diabetics. But if the patient is faint or frequent hypoglycemic episode, right? Like a patient is diabetic and patient is take medication, maybe something wrong, lack of knowledge, and frequently attack of hypoglycemia. Maybe they need to learn or need some medication or education. The American Diabetic Association allow a goal up to 8% if the patient have a frequent hypoglycemic episode, because hypoglycemia also dangerous. It is danger than more than hyperglycemia. So if hemoglobin A1C level 6.5 or higher, the patient has type 2 diabetes with a history of primary hypertension and the use of hydrochlorothiazide, it is diuretics, which can have some diuretics-induced renal impairment. And this patient is also at moderately increased the risk for a very uncommon but serious and potential life-threatening conditions like lactic acidosis when using the metformin. Metformin for what? Because of diabetics type 2. Has the diuretics have been associated with hyperglycemia? So need to check hemoglobin A1C would help for better understanding the role that this medication can be play in the glucose level seen in recent lab test. What else? Here is a few information about pherecytoma. Pherecytoma is a tumor of adrenal medulla, not adrenal cortex, and that secrete excessive catecholamine. So catecholamines actually epinephrine and norepinephrine, that is increased blood pressure. It causes hypertension, diaphoresis, means sweating or sweating, headache, tachycardia, hyperglycemia, hypermetabolism, and weight loss. So this is very important, the presentation of hyperglycemia, presentation of pherecytoma. So easy way to remember, pherecytoma increase or excessive catecholamine, right? Increase the catecholamine. Blood pressure increase, hypertension. Sweating increase, diaphoresis. Headache, it is also showing symptom of increase. Tachycardia means heart rate increase. Hyperglycemia, blood sugar increase, right? Hypermetabolism, metabolism rate increase, but weight loss, right? But weight loss, not weight gain. So everything is increased except weight loss. right? Let me recap it. I said hypermetabolism, metabolism rate increase, hyperglycemia, blood sugar increase, increased heart rate, tachycardia, headache increase, sweating increase, diaphoresis, hypertension, blood pressure increase, because catecholamine increase. Catecholamine increase because of pheochromocytoma, which is the tumor of adrenal medulla, right? So example, this is the kidney, right? Everybody know we have two kidneys. In the kidney has a one gland is called suprarenal gland is here. And this suprarenal gland, outer layer we call cortex. This is the cortex. And inner layer or inside, it is inside here, this is called medulla. And medulla has a cell, it's called enterochromatic field cell. If the tumor developed and this area have any tumor, and this tumor secret too much androgen hormone, okay, because of adrenal medulla tumor and catecholamine secret, and they causes all of this problem. We learn, right? So what next? Next here, it is characterized by high fasting blood glucose in the morning. That is caused by the secretion of glucagon by the liver. And this is the medical phenomenon for diabetic patient. It is called Somogai phenomenon or Somogai effect. What is that? A patient has a diabetic, but patient blood sugar level is increased in early morning. So it is characterized by high fasting blood glucose in the morning. Morning means not 8 a.m., not 7 a.m. Morning means in the midnight, 2 a.m., 3 p.m. And this causes because at the night time, liver secret glucagon. What you can do, my friend, you check the patient blood sugar early morning at the 3 a.m., 2 a.m. So Somogai phenomenon occur when nocturnal means the midnight, hypoglycemia, right? Why? Because high fasting blood glucose in the morning. So because stimulation of the liver to promote glucagon, which causes the fasting blood glucose to become elevated. It is also known as rebound phenomenon. So important, let me tell you, fasting blood glucose level go up when patient present with hypoglycemia. Okay, don't miss too. Next here. Okay. So it is the question or information about research, okay, or evidence-based practice. So the correct symbol to indicate the total number of the subject in a study, like you went in a geographical area, and in the geographical area, total number of the population you want to study. So total population in a study, we mentioned by the letter N, capital N. For example, research study has a total number of subject or total population is 100. So it is difficult to write every time total number. So we use a symbol is called capital N. So if board asks in a research study, How will we represent the total number of the subject or population by N? Or in the research study, N sample for what? N sample for total number of the subject or population. The small number N is used to indicate subpopulation. So for example, so here we learn 2 points, my friend. One is capital N, another is small n. Capital M represents total number of the population, but small n represents subpopulation. For example, a study used a total population capital N 100 that is divided into 2 groups, 50 subject. So small n is 50. Okay, so there are 2 more symbol. Is letter called P. P stands for used to indicate p-value. The symbol alpha is denote the significant level. It is, I told you, this symbol we use for research. So here, what is that? The 2 guidelines. It is called ACC and AHA, guideline for anticoagulant for the patient with prostatic valve suggest an INR supposed to 2.5 to 3.5, right? So here, so the guideline, according to the guideline, anticoagulant patient with who have a prostatic valve suggest international normalized ratio supposed to 2.5 to 3.5. It is normal. They are the risks for blood clot because prostatic valve. So question, if a patient need to prostatic valve, what should be their INR range? INR range supposed to be 2.5 to 3.5, and it is normal. Why? Because the person who use prostatic valve, they have a chance to develop the blood clot. What next? So a question or information about the musculoskeletal system. The musculoskeletal system is not damaged by NSAID. So the person who have some complication or disease related to musculoskeletal system, if you give them non-steroidal anti-inflammatory medication, it is not good, bad for them. In fact, non-steroidal anti-inflammatory NSAID are used to treat muscle and or joint pain and inflammation. So musculoskeletal problem causes the joint pain, causes the inflammation. NSAID reduce the pain and reduce the inflammation. Systemic adversely affected by NSAID include cardiovascular and hemopoietic and integumentary system. So NSAID is not good for cardiovascular or hematopoietic system because aspirin affect the platelet. Also, NSAID is not good for integumentary. Why? Sometimes some patients complain the complication like Stevens-Johnson syndrome. What next? A patient is presenting with the sign of subclassical hypothyroidism. So if patient has a hypothyroidism, and if you check TSS, T3 and T4, what we can see? Let me tell you something. So patient has a hypothyroidism, right? So you need to check TSH, means thyroid stimulating hormone. So hypothyroidism, TSH always go up, but T3 or T4 always go down. So how I remember for my board exam, I remember hypo means reduce, T3 and T4 reduce, but opposite TSS increase. In case of hyperthyroidism, T3, T4 increase, but TSS go down. Let me read it. Hypothyroidism, free T4, it is called thyroxine. T4 is normal and TSS is elevated. Don't confused. I told you hypothyroidism patient T3, T4 go down, TSS go up. But every patient is not same. Some patient maybe T4 is normal, T3 is normal, but TSS go up. Still, this patient have a hypothyroidism. You need to recheck it. So this patient has a hypothyroidism. Free thyroxine is normal, but TSS is elevated. Maybe it is normal today. After 1 month, if it's untreated, if you do not take action, it should be go down. So a normal free T4 range between 0.8 to 1.8 Ng plus nanogram per DL. And the normal TSS range 0.4 to 4.0 TSS level. The patient maybe start on the low dose of levothyroxine. So my patient, TSS go up, T3 or T4, maybe it's still today is normal, but a typical presentation of hypothyroidism, T3, T4 go down as well. I need give them T4 and T3 replacement, thyroid hormone replacement therapy. And this is called levothyroxine. How we remember this for my board exam? I remember if my patient has a hypothyroidism, hypo for O, my medication levo for O. So hypo O, levothyroxine O, when OO is matched, means this is the medication for my patient. My patient has a hypothyroidism. If my patient has a hyperthyroidism, like Graves' disease, I give them profile uracil, shortly called PTU. Like, it is easy to remember, very small things, but a big help for board exam. Profile uracil is used in the treatment of hyperthyroidism. The signs of hyperthyroidism are insomnia, tachycardia, increased blood pressure, and weight loss. Okay. And another medication is called memantine, is used to treat severe dementia. It is not related to this question, but I want to tell you, please remember this medication name. Memantine is used to treat severe dementia in Alzheimer's diseases. One of the tests called MMSE result in the cause were minimal with the score 28. So mini mental test we do for the patient who have cognitive defect like Alzheimer's disease, right? And some questionable significant. So there is no need for mementin because mini mental study within the normal range. So you see how we give the treatment to the patient. Another medication most popular for our patients called carbidopa. Carbidopa always give with levodopa. It is called Nsaid. It is a treat for the Parkinson disease, which present with the tremor at the rest, muscle rigidity, and shuffling gait or weight, bradykinesia, and depression. What we learn from here, my friend? We learn a wonderful message from this. If my patient has a Parkinson disease or Parkinsonian syndrome, the patient present with tremor, and this tremor, even in the rest, we call resting tremor, muscle rigidity, and movement problem. It is called shuffling gait or shuffling walk, slow movement, slow heart rate, bradykinesia, and also depression, right? Oh my God, depression. We have to know we need change. So if patient have Parkinson, what are the treatment? I give them levodopa. But levodopa is not good to transport in my brain. They need help. You give them carbidopa. Levodopa combined with carbidopa and make a bond, carbidopa, levodopa, and transmit to the brain. They cross the blood-brain barrier. Levodopa, another name is Nsaid, the treatment for Parkinson's disease. But my patient has another patient has Alzheimer's disease. You know, the most common cause of dementia, severe dementia. But when a patient has Alzheimer's, we start the treatment. You need to check mini mental test. If it is the score less than 25, you can start the medication, right? And medication called mementin. Next, the normal free T4 range between 0.8 to 1.8 nanogram per DL. The normal range for T4. The normal range for TSS range 0.04 to 4. How I could remember? Right? I need to remember. Tell your brain I want to remember. So TSS 0.4 to 4.4, 4.0, right? And T4 0.8 to 1.8. So I want to say there are no magic, but if you tell your brain, I want to remember for my exam, definitely you will remember. Next here, erythromycin. Erythromycin is an antibiotics, and another medication called telithromycin are contraindicated in the patient with myasthenia gravis because of potential respiratory collapse. So if my patient has a myasthenia gravis, and you know myasthenia gravis patient is died because of weakness or paralysis of respiratory muscle, so it is good to not to give them erythromycin because erythromycin is a contraindicated in the patient who have myasthenia gravis. Why? Because chance of potential respiratory collapse. antibiotics that are safe for prescription for the patient with myasthenia gravis and pertussis are azithromycin or clarithromycin. Doxycycline is not indicated for the treatment of pertussis. Next is one of the medication is called pioglitazone. This medication is contraindicated in the patient with class 3 or 4 heart disease and congestive heart failure because it causes the water retention. And pioglitazone should also be avoided in the patient with a history of bladder cancer. So if patient has a diabetic and if patient diabetic with heart disease or diabetics with bladder problem, we never ever give them pioglitazone because pioglitazone should be avoided in the patient with a history of bladder cancer or history of congestive heart failure or class 3 and 4 heart diseases because can cause water retention. So if patient have this, and what are the drug of choice, right? We need to find out. So biguanide are contraindicated in the patient with renal or kidney disease. So if a patient has a diabetic with a kidney problem, it is good to avoid biguanide. Right? Asthma is not a contraindication for diabetic medication. So asthma and diabetic, you can give them those kind of medication, right? Another information here is potassium sparing diuretics. So patient with a sulfur allergy may be sensitive to thiazide, loop diuretics, and some protease inhibitor, right? So what we could do, so which are used to the treatment of ASIB? Potassium sparing diuretics are safe alternate for the patient with a severe sulfur allergy. So if patient need the medication, but they have an allergy to sulfur, we give them potassium sparing diuretics, right? So because sulfur allergy patient may be sensitive to thiazide, loop diuretics, and some protease inhibitor, like they said here, darunavir antiviral, which is used to the treatment of ASIB. But potassium sparing diuretics are the safe alternate for patient with a severe sulfur allergy. Next here, a patient likely has Ray's syndrome, which is a very uncommon condition that can develop in the children and young adult recuperating from febrile viral infection who ingest aspirin or salicylic medication. Imagine a children who have a fever and mother do not know, and mother gave the Nsaid or aspirin or salicylic acid, and patient develop the complication we call Ryle syndrome, right? So this condition can progress very quickly. Stage 1 symptoms are severe vomiting, diarrhea, lethargy, stupor, and elevated ALT and AST. So patients who have a Ryle syndrome, very stage 1, severe vomiting, because vomiting, when baby have a vomiting, and it lead to hypovolemic shock, or if patient has a diarrhea, lead to hypovolemia, and all together lead to the lethargy and stupor. If you check liver enzyme, ALT and AST is elevated. In stage 2, patient have personality change, irritabilities, aggression, and hypertension, hyperactive, and also hyperactive reflexes. Ryle syndrome we are talking about. If patient stage 3 to 5 present with confusion, delirium, cerebral edema, coma, seizure, and death. So from this note, we learn some information that Ryle syndrome different stages. What are the presentation? Stage 1, stage 2, and stage 3 to 5, right? So what next? Next here, the effect of ibuprofen. It inhibits the effect of renal prostaglandin and blunt the effectiveness of diuretics. Non-steroidal anti-inflammatory drugs, shortly called NSAID, and salicylic acid inhibit the vasodilatory effect of prostaglandin. So vasodilation, which predispose the kidney to ischemia. NSAID can cause acute kidney injuries by decreasing renal blood flow. So NSAID is not good for kidney, right? For a long time. So non-selective NSAID can adversely affect the kidney, also gastrointestinal tract, liver, cardiovascular system, and lungs, can cause bronchospasm. What next? Here, the side effect of thiazide diuretics such as hydrochlorothiazide are hyperglycemia, hyperuremia, and hypertriglycemia, also hypercholesterolemia. So the patient should also be monitored for hypokalemia, hyponatremia, and hypomagnesemia. So if your patient need thiazide diuretics, like patient has a high blood pressure, you give them thiazide diuretics like hydrochlorothiazide. What we have to monitor, because this medication can cause hyperglycemia, blood glucose level go up, hyperuricemia, uric acid level go up, and hypertriglyceridemia, means triglyceride level go up, and also hypercholesterolemia, cholesterol level go up. So we need to check lipid profile, we need to check blood sugar, and we need to check blood urea level. Patient should also be monitored for hypokalemia. So you see, most of them get up, blood sugar level go up, uremia level go up, triglyceride level go up, cholesterol level go up, but potassium level go down, sodium level go down, and magnesium level go down. So don't make confused. So few go up and few go down, right? Because thiazide diuretics, such as hydrochlorothiazide, this increase the blood sugar, increase the uremia, increase triglyceride, hypercholesterol, but reduce potassium, reduce sodium, and reduce magnesium. Important for board exam, and keep it in mind. So here the few of the information about the treatment of chlamydia. Chlamydia is a sexually transmitted infection, most common in America. And we treat chlamydia by erythromycin. And erythromycin 1 gram PO in a single dose. If a patient has a positive nucleic acid amplification test for chlamydia trichomoniasis, so whatever it is, make it easy. If a patient is positive for chlamydia trichomoniasis, both the patient and their sexual partner should be treated, right? Should be treated with erythromycin. While erythromycin 1 gram PO in a single dose or doxycycline 100 milligram PO 7 days are recommended the regimes. Erythromycin is preferred the treatment due to the compliance advantage of a single dose. Because of single dose, patient prefer it, but doxycycline 100 milligrams 7 days. But remember, erythromycin 1 gram, and this is doxycycline 100 milligram. So clindamycin is not the recommended, as it is the only partially effective for eradicating chlamydia trichomoniasis in men with a non-gonococcal ureoarthritis. Benzathine is used to treat the syphilis, not for chlamydia. So what we learn from here? We learn 3 information, right? 1, if patient has syphilis, we give them benzathine penicillin. If my patient have chlamydia, we can give erythromycin, but it should be 1 gram. Advantage single dose. If erythromycin any kind of contraindication or not too good for my patient, we choose doxycycline, but 100 milligram and 7 days is the recommendation regime for the patient who have chlamydia trichomoniasis is positive. Next here,